Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. What's going on in this image? It's a cartoon representing angina. Yeah. Do you know the differential diagnosis for this? STEMI, NSTEMI. Usually it's musculoskeletal pain. Have your radars up. We're going to be talking about this and much more in this presentation on Ischemic Heart Disease Pathology. Everything that you need to know is covered in this book, Medical School Pathology and Step 1 Review. It has everything in it that you need to do the best on Step 1. Live up to your potential, set your foundation. Let's get started. Ischemic heart disease. That is a group of syndromes associated with myocardial ischemia. Here's a cartoon representation of ischemic heart disease that resulted in myocardial infarction. Based on the cartoon, which vessel was occluded? If you're thinking LAD, then that's all right with me, right? And notice the transmural lesion there, right? Myocardial infarction. So ischemic heart disease is the major cause of death in the USA. Ischemic heart disease is typically brought on by coronary artery atherosclerosis. You remember we talked about that? With the plaque that accumulates, the macrophages, the calcium buildup, all of that. So that lesion actually reduces the blood flow to the myocardium. Risk factors for ischemic heart disease include poor diet, cholesterol, smoking, and advancement in age. Here we have an tracing, or a tracing, of ischemic heart disease, particularly Prinzmetal angina. And here we have various histologic representations of mesenchymal stromal cells that were actually taken and utilized to repair a patient's cardiovascular tissue that was undergoing ischemic heart disease. Isn't that fantastic? Science does wonders. You're in the right field. Now let's talk a bit about stable angina. We all know what that is, right? As a result of physical activity or emotional stress, chest pain may occur due to stable angina. Stable angina is usually the result of atherosclerosis of coronary arteries with less than, important number, 70, that's 70% stenosis. Less than that, stable angina. I'm sure you can guess if it's more than that what's going to happen. We'll talk about that. In stable angina, reduced blood flow is not able to meet the metabolic demands of the myocardium during exertion. Stable angina represents damage that myocytes can recover from, hence reversible issues, hence no necrosis. Symptoms of stable angina may include chest pain with exertion that lasts about 15 minutes, pain that radiates from the chest to the left arm associated with exertion, diaphoresis, and shortness of breath. The classical electrocardiogram findings of stable angina show ST segment depression. ST segment depression. The ST segment depression is due to subendocardial ischemia. And how do we treat stable angina? Well, rest, take a breather, and maybe a little NO, right? Rest and nitroglycerin. Regarding unstable angina, this is chest pain that occurs with rest, and that is unstable angina. Here's an illustration of a man that was just relaxing and out of nowhere had chest pain. Unstable angina. Unstable angina is usually due to rupture of atherosclerotic plaque with thrombosis with incomplete occlusion of a coronary artery, such as the LAD or right coronary artery. Unstable angina represents damage that myocytes can recover from. Hence again, no necrosis. Electrocardiogram of unstable angina shows ST segment depression because of subendocardial ischemia. An unstable angina is relieved by nitroglycerin. Now you might be wondering, why nitroglycerin? Well, remember, nitroglycerin acts on the smooth muscles of those vessels, causing them to dilate. And when they do that, the vessel diameter actually increases, allowing more blood to pass through and reach the end targets. Patients with unstable angina are at increased risk of progression to myocardial infarction. Let's talk about a different type of angina called Prinzmetal angina. Now this one is very high yield because it shows up a lot. Prinzmetal angina is episodic chest pain that is not related to exertion. Prinzmetal angina is episodic chest pain that is not related to exertion. Got it? Prinzmetal angina is due to coronary artery vasospasm and represents damage that myocytes can recover from. Hence again, no necrosis. The electrocardiogram of Prinzmetal angina shows ST segment elevation, and that's due to transmural ischemia. Treatment of Prinzmetal angina includes nitroglycerin and calcium channel blockers. Why calcium channel blockers? Well, it's the release of calcium that causes that contraction, right? But if you block the channels, there's less contraction of those smooth muscles and the vessels stay open, preventing Prinzmetal angina. And we already know what nitroglycerin does, right? Here's an electrocardiogram from a patient experiencing Prinzmetal angina. Now let's move on and talk about myocardial infarction. I know you've been waiting for this. Now with myocardial infarction, there's necrosis of cardiac myocytes that occurs. This has necrosis. Myocardial infarction usually occurs due to rupture of an atherosclerotic plaque with thrombosis and complete occlusion of a coronary artery. Risk factors of myocardial infarction include coronary artery vasospasm, such as that due to Prinzmetal angina or cocaine use. Emboli can do this, as well as vasculitis, like Kawasaki disease. You remember Kawasaki disease? Young child with strawberry tongue and heart issues, right? The heart issues should clue you in on vasculitis and myocardial infarction. Also, a clinical vignette to be aware of is a myocardial infarction in a bro-y type of male that went out, used cocaine in some way, shape, or form, and showed up to the ER with severe chest pain. So have myocardial infarction on the differential. Clinical features of myocardial infarction include severe chest pain that radiates to the left arm, sweating, otherwise known as diaphoresis, and dyspnea. Symptoms of myocardial infarction are not relieved by nitroglycerin. The left ventricle is typically affected by infarction, while the right ventricle and both atria are typically spared. And the rationale behind that is because the left anterior descending artery is usually the one that's obstructed. As we can see here, note, the right coronary artery is the second most prevalent involved artery in myocardial infarction. And to the right, we can see the ECG from a patient that experienced right coronary artery STEMI. Now, the classic cardiac vessel occlusion shows for occlusion of the left anterior descending artery that results in an infarction of the anterior wall and anterior septum of the left ventricle. Occlusion of the right coronary artery results in infarction of the posterior wall, posterior septum, and papillary muscle of the left ventricle. And occlusion of the left circumflex artery results in infarction of the left lateral wall of the left ventricle. In general. Now, the initial phase of myocardial infarction results in subendocardial necrosis, involving less than 50% of the myocardial thickness. Therefore, it's termed as subendocardial infarction. And the EKG shows ST segment depression. Continued or severe ischemia leads to transmural necrosis, involving most of the myocardial wall. So this is a full-on transmural infarction. And the ECG, echocardiogram, shows ST segment elevation. Laboratory findings of myocardial infarction show elevated lactate dehydrogenase levels, elevated troponin, and elevated CKMB. Now pay attention to this because this is important. Troponin I is the most sensitive and specific marker for detecting myocardial infarction. It's the gold standard. And regarding troponin I levels in a myocardial infarction, they rise typically 2 to 4 hours after an infarction and peak at 24 hours and return to normalcy in about a week to 10 days. CKMB is helpful to detect re-infarction that occurs days after an initial myocardial infarction. Creatine kinase MB levels rise 4 to 6 hours after infarction and peak at 24 hours and return to normal in about 72 hours or 3 days. Now, important, the treatment of a myocardial infarction involves Monabage. That is Monabage, M for morphine, O for oxygen, N for nitroglycerin, A for aspirin, B for beta blockers, A for ACE inhibitor, S for statin, and H for heparin. Monabage. The treatment of a myocardial infarction may result in reperfusion injury. Here we have an example of a myocardial infarction identified by a late gadolinium enhancement. And here we have more imaging showcasing myocardial infarction. This patient actually experienced a STEMI. On the topic of reperfusion injury, what is that exactly? Well, a reperfusion injury is due to reperfusion of irreversibly damaged myocardial cells that leads to a calcium influx. The calcium influx causes a squeeze, a hypercontraction of the myofibrils. Therefore, there will be this contraction band necrosis. The return of oxygen and inflammatory cells can result in free radical generation, which further damages the myocytes, resulting in reperfusion injury. Now, this is very important. You'll definitely see this. Sudden cardiac death. Now, sudden cardiac death is the unexpected death because of cardiac disease. Sudden cardiac death occurs without symptoms or less than 1 hour after symptoms show up. Sudden cardiac death is typically due to a fatal ventricular arrhythmia or an acute ischemia, which is the most common etiology. Risk factors for sudden cardiac death include atherosclerosis, mitral valve prolapse, cardiomyopathy, and cocaine abuse. Say no to drugs. 90% of patients that die from sudden cardiac death have pre-existing severe atherosclerosis. Here we can see some post-mortem histopathology that actually correlate with an MR image and CT image in patients with death secondary to primary vascular causes. And here we have the ECGs of two sisters, both of whom experienced sudden cardiac arrest. Now let's talk a bit about chronic ischemic heart disease. Chronic ischemic heart disease results in poor myocardial function because of chronic ischemic damage. And this can be with or without infarction. To the right here, we have a coronary artery that has its lumen diminish significantly due to the accumulation of plaque and atherosclerosis. Chronic ischemic heart disease may progress to congestive heart failure. And you may progress on to the next lecture because you win again. Congrats. Beautiful, beautiful. You're doing an amazing job. You know so much. You're just adding and adding on to your knowledge base. You know so much. You're going to rock out. I believe in you. Everyone believes in you. Keep up the good work, and I'll see you later.